So, hi there again. My name is Nens van Alfen. I'm an associate professor of neurology at the Radboud University Medical Center in Nijmegen, the Netherlands. And I would like to thank the organizers again for inviting me to talk about quantitative muscle ultrasound. This time with a little more practice-based talk of its potential role in neuromuscular disease. So the topics of my talk will be a very quick introduction for those of you who haven't seen the previous presentation. And then two case examples. One, how you could use quantitative muscle ultrasound screening for classic neuromuscular diseases. And two, how you could use it to screen for rapidly progressive weakness. Then we're going to do a quick quiz case for you. And then I have some messages I hope you will take to work with you. Now, briefly, muscle ultrasound is basically the story of these 256 shades of gray, from completely black to completely white. And here you see the primary example of that. These are two sets of images from the calf muscles. So the one on the left are healthy, and they show you a transverse image in the top left of the gastrocnemius and the soleus muscle lying on top of each other. Oh, sorry. And then in the lower left, there is a longitudinal image where you very nicely see the pennation angles of the fibers and some some blood vessels coursing through the muscle. Now the image on the right is pathology. So here the muscle has been replaced by a very dense white tissue consisting of fibrosis and maybe a little fat. This is a muscle that's been completely denervated in this case. And if it's like this, I don't think you will have any problem with using muscle ultrasound because this is easy to see, right? So what happens here is that if you have intramuscular pathology, this will cause muscle fibers to become interspersed with other tissue types, such as fat and fibrosis. And this will give you a lot of tissue transitions where the ultrasound is reflected back to your screen. So all these tissue transitions, as shown on the top, the lower right there, they will end up giving you a lot of white pixels and hence a very echogenic muscle. And because the ultrasound is already sort of reflected back in those top dense layers, not a lot of it will get through to the deeper layers. And that is something called attenuation. And both phenomena, so a very dense white muscle, attenuation, and then also that you can't really see the texture of the muscle anymore. These are the basics of muscle ultrasound imaging. Now, in the 1980s, Sidney Heckmat developed these three characteristics into a grading scale. So here you see the Heckmat scale from 1, which is normal, to 4, which is most abnormal. And again, in scale grade number 1, you can see a healthy looking muscle. You can see its erectus femoris by its typical texture. You can look through it to see the vastus intermedius and the femur. But if the muscle becomes diseased, as in grade 2, you can see the muscle itself will become a little more white at first, but you can still see its muscle and you can still see through it. And then the texture gets disrupted and there will be attenuation, so the bone shadow will be harder to see. And then in grade 4, it's all dense tissue mass, but you can't even recognize it as muscle anymore. You can't see through it. So if you keep this in mind, this is how we're going to look at the images that will follow. The other thing that we can do is fully quantify, for example, this echogenicity measurement. So then you need a graphic software tool as Adobe Photoshop or ImageJ, which I've used here. That is freeware, by the way. And you can take the image, place a region of interest, the red rectangle, have the software calculate the histogram for all the gray values that are in here, from black, which is 0, to 255, which is completely white. And you get this mean gray value, which is 42 point something here. And if you have that, you can also measure healthy people, their muscles, and then calculate reference values. And with that, you can say how many standard deviations the echogenicity of your muscle image is above or below the mean. And that's called a z-score. Now let's show you a practice example. Here is ultrasound as we use it as a quick screening exam for kids. So this is a case of a 3-year-old boy who was referred by a pediatrician elsewhere because of delayed motor milestones. His parents told us that he could only walk at the age of 2, which was significantly later, for example, than his healthy older sister. And he can't really run, and he fatigues real easily when he exercises. The other thing the pediatricians had found was that there was an unexplained elevated liver enzymes, and they couldn't really tie those two pieces of information together. So we got him for a tertiary referral. Well, you have this ultrasound machine in your exam room, and you take a look at the calves. Here you see the anatomy of the image, the subcutaneous fat, the gastroc, the soleus, the deep flexor layers. And these are already images from this patient. And when I take the anatomy out, you can appreciate that even on the left, these muscles are white and much whiter, for example, than the subcutaneous layer, which they should, compare to. So on the left, you see a HECMAT grade 2 calf muscle, and on the right, it's a grade 4. And just by eyeballing these images, which you can literally create if you have the ultrasound scanner ready in less than 30 seconds, you know that you need to proceed with a neuromuscular screen in this kid. Now, if we do the full quantified muscle ultrasound here, now all the muscles that are abnormal are highlighted in black. You can see that all of them have abnormal Z-scores. So this is a generalized neuromuscular pathology. And I don't think in this case, I didn't mean to make this very hard or something, you will not be surprised that this boy had a very highly elevated CK level. And when we tested him genetically, he had a dystrophy mutation. The only reason this boy also got a muscle biopsy as a fourth line diagnostic was because the mutation was kind of odd in that it predicted a Becker phenotype, and he didn't have that. So in the end, in the biopsy, it was shown that he had no dystrophy type 2. So let's look at some of the literature out there on ultrasound and Duchenne's. Ultrasound was invented in sort of the 1980s, so I took that as a starting point for my search. And you can see that there's 380 plus papers out there already on this topic. You can also see, and I've put the images from the first study there, that the ultrasound quality has changed quite a lot over time. So to me, these first images of the quadriceps, they sort of look like sonar looking at the floor of the sea. But right now we have very nice tissue resolution. So there's been a lot of improvement in technique over the years. Now, because it's too much to show you all the 382 papers, but these are the highlights, and I've selected a few of them. And I think the good thing to know is that the ultrasound is very sensitive to pathology in these classic neuromuscular disorders. So the changes will appear before any clinical symptoms, even from the age of 2, 1.5. And the same goes for follow-up. Before the functional measures change, the ultrasound would already predict them. And this is important if you want to do a natural history study or a trial. So if you have the somewhat younger kids, younger than 7, you know that with ultrasound, you will expect to see a change after a year. If they are older, already after 6 months with ultrasound. And if you do a trial and the kid deviates from his line, so to speak, in that time, you know that your therapy is doing something. Now, the nice thing is that ultrasound also monitors respiratory function really well, so the diaphragm, for example. And you can also look for dysphagia, especially in Duchenne and Becker patients. It has been shown that the submental and masticatory muscles, so like masseter and the muscles here in the floor of your mouth, they are good predictors of whether the child will need speech and language therapy. Just to show you an example of what ultrasound may look like as a biomarker here for the natural history. This is a healthy kid on the left, biceps brachii, brachialis, and then the biceps brachii of a Duchenne boy. When I take the anatomy out, you can see the ultrasound images a little better. And you can see that progressively the muscle becomes very dense, very white, as we have seen before. And in the 16-year-old young man with Duchenne's, there is no bone to be seen. But the other thing that you might appreciate here is that there is no atrophy. So in Duchenne's, we don't see any muscle atrophy. And that's good to know because in this case, muscle thickness is not a very good biomarker. You need to look at the structural changes. So is it valuable? Well, yes, because there's a good correlation here. We see muscle ultrasound gray value in the left graph on the y-axis, and you see age, which is sort of equated with disease progression on the x-axis. And there's a very steep correlation between the two. And in reverse, if you look at the childhood myositis assessment scale, which is a functional measure for kids with neuromuscular disease, you see a very steep decrease of function with increasing echo intensities. So it's a good correlation with clinical relevant measures. But it doesn't only work in Duchenne's. Here's another classic neuromuscular disorder, FSHD, where we performed a one-year study of 218 muscles. So it was a repeated measurements design. And after 1 year, we saw that in this cohort, no one changed clinically in a meaningful way. So there were some slight changes, but at the group level, it just didn't figure out. So if you did a trial again, then you would have to look for much longer than that year to find any clinically meaningful changes. But the ultrasound did, and it did both with the quantitative analysis, where sort of 1/3 of the muscles had a Z-score increase, and in the just eyeballing the muscle and using that HACMAT grading scale, you can also see that some of them increased. There was a good correlation between the two. So to me, this says that if you want to do a trial, I think you'd best use the quantitative results, and you don't even need references because the patient at time point 0 will be his or her own reference in the end. But just for clinical practice, you're probably okay by just looking at those muscles. So in summary, quantitative muscle ultrasound in classic neuromuscular diseases like these muscle dystrophies is excellent for the detection of structural muscle abnormalities. It's more sensitive than tracking your clinical symptoms, and it's correlated well to overall function. And if you have some experience, you could probably also do this with visual screening. Let's look at the second practice example. How could quantitative muscle ultrasound help you diagnose rapidly progressive weakness? Well, this is a 79-year-old female with a history of a distal radius fracture, but then she developed a weakness of her right arm and shoulder. It was progressive. It also included the left arm a few months later, and she had no other signs or symptoms. So no sensory problems. I'm going to show you the video again. Her reflexes were normal, and she had a pretty non-existent medical history. Now you can see very severe weakness here, and I need to assure you that she didn't have any frozen shoulder or other, passive range of motion limitations. So when we screened her, these are the ultrasound results for her upper extremity. I'm just going to show you the biceps images. We took a few more, but and on the left, I've put a normal biceps brachii for this person. So what should the image look like versus on the right? What was it in her case? Well, you can see a clearly abnormal biceps there in this lady with an abnormal Z-score. And the same goes for her lower extremity. So on the left, you see a normal rectus femoris with a normal vastus intermedius. And on the right is again the image from this lady, which is clearly not okay. But the next step was equally important because we again looked at her biceps for a little longer this time. So this is an ultrasound video. And you see all those tiny little quirky movements in the muscle. And these are ultrasound fasciculations. Just going to show you this one more time. Of course, you see a pulsating vessel there, but also these tiny jerky movements. So with this clinical phenotype and the results of the ultrasound screen, as shown here, both echogenicity on the left and fasciculation counting on the right, we had a clear suspicion in this lady of a motor neuron disease. And in our practice, we are used to always combining needle EMG and ultrasound for these cases, because that will give you the best diagnostic results. If this is the needle EMG, I'm sorry about some of the Dutch words that are still in here, but I think you can appreciate that there were fibrillations and positive spikes in several of these muscles in several regions. She had fasciculations in a number of muscles, and it was a very neurogenic recruitment pattern. So this confirmed our clinical suspicion. And this lady is, we think, a flail arm variant of motor neuron disease, or we would call that a woman in the barrel. I think that the formal term is man in the barrel, but she obviously isn't so. So if we look at ALS a little more specifically, like we did for Duchenne's, you can see that since the 1980s, there's been about 200 plus studies on ultrasound and this disorder. And basically, what we do with ultrasound in ALS is something that is quite alike to your EMG, following the Ellis-Corial or Awagi criteria. So we look at 4 regions: cranial, cervical, abdominal, thoracic, and lumbar. And then we screen 2 to 3 muscles per region bilaterally. And there's been some diagnostic algorithms calculated that say that it's very suspect for ALS if you have, for example, a Z-score of more than 1.5 in at least 2 muscles and fasciculations in more than 4. Or you could even sort of trim the whole thing down to just screening fasciculations. And it's already very suspect for ALS if you have more than 2 out of 9 muscles that show fasciculation. Now let's look at those fasciculation screening studies some more. So ultrasound is really good at screening fasciculations because you have a very large pickup area. The screen size is usually something like 4 by 6 centimeters or something, which is much larger than the pickup area of an EMG needle. So you find a lot more fascics. The optimal scan time, as shown in this slide, is not a lot different than for EMG. It's 30 seconds at least, preferably even 60 if you want to be really sensitive. And what we know about ALS is that these fascics have a temporal detection window. So when patients come to your office for the first time, usually about 50 to 60% of them will show fasciculations in their muscles. Somewhat later, this will increase to almost 100% for the cervical region. But when the disease progresses and these people become worse, their muscles become atrophic and weak, and then they can't fasciculate anymore. So it has a temporal dynamic in it. If we look at muscle echogenicity in ALS, there's a really common pattern at the time of diagnosis. So these people have prominent fasciculations in the muscles that do fasciculate. They have a few muscles with abnormal echogenicity usually, and then very few with atrophy at that time. If you use this combined protocol, you have a very high sensitivity and specificity, which is quite similar to just using EMG. And then again, the beauty of this is don't use either, use both, because then you give 25% of your patients a more certain diagnosis. Now, people have also looked at biomarker function in ALS, for example, with muscle thickness. And basically what's been found is that the only really associated thickness measurement was the geniohyoid, which is a muscle in the tongue base. It might be useful as a trial marker, but this needs some more work. And I think the same goes for the echogenicity. There have been some conflicting results. So one group has found a very small increase per week in the echogenicity overall at a group level, but another study, which was a bit larger, didn't show any real clear correlation, and that's what's on this graph and slide. So this will need work too. And I think we've already discussed why muscle ultrasound is not good for follow-up here, because on the one hand, fasciculations, which are a major part of the diagnostic value, they tend to become less. And on the other hand, patients also have central motor neuron pathology, which will impact their function and prognosis. And that's also not accounted for in the ultrasound measurements. So good for diagnosis, less so for follow-up. Now let's go to that quiz case. We saw this female, she was 44 years old. Again, no really relevant medical history prior. She had a stat referral to our neuromuscular clinic because she experienced severe proximal weakness, shoulder girdle, pelvic girdle, head drop over the past few weeks. And she was very fatigued. There was no pain, but her muscles felt really stiff. Again, her muscle ultrasound results compared to a normal example on the left. And something weird is going on here. So this is biceps, brachialis, humerus. When I take the anatomy out, you can see that her muscles are really white. So the echogenicity is quite high, but you can still see through it. So there is no attenuation of the ultrasound beam here. And that is an unusual combination that you almost always see when there is edema. And edema, I think, equals with inflammation in this case. And if you look well, you can also see that the subcutaneous layers here, it's also more echogenic than the other one. So there's something going on with both muscle and the skin system. Same here in the forearm flexors of both arms, and again a healthy image on the left with the flexocarpi, the deep finger flexors there indicated. If I take the anatomy out, you can again see that diffuse hyperechogenicity without attenuation, and this has also been dubbed see-through echogenicity increase, very indicative of edema, and the subcutaneous layer again is not okay. Well, if we look in the leg, this is a little less pronounced on a muscle level, so it's vastus lateralis, vastus intermedius over the femur. If I take the anatomy out, the most abnormal parts here are those fascial and subcutaneous layers. The muscle actually doesn't look that bad in this case. And if we go to the calves, so medial gastroc, soleus, same pattern, abnormal subcutaneous layer, reasonably okay muscle. Now, these are the full screening results, which are very similar to what we've just seen. And she was, the history with the quickly, rapidly progressive weakness, the stiffness, and these findings of abnormal muscles, abnormal subcutis, were very suspect of a specific inflammatory myopathy. And the workup further showed that this lady had an anti-HMGCR antibody positive necrotizing immune myopathy, which is very incapacitating. So she was started on a high dose steroids, azathioprine was added immediately, but she still deteriorated further. So we had to add intravenous gamma globulins. And then she stabilized, and a year later, she was almost back to normal. And actually the normal images I've shown you here on the left side of the slides, they were from her in the follow-up phase. So again, quantitative muscle ultrasound for rapid onset weakness. It's easy. You can do the screening bedside or in your outpatient clinic. It's pain-free. It has high sensitivities reported for important diagnoses such as ALS or inflammatory myopathies. And you could also use it in the ICU to predict ICU-acquired weakness. So, your take-to-work messages, what this technique might do for you. Well, again, it's a painless point of care, and you can use it in your office. Many of these ultrasound machines are portable, so you can just take them with you to the patient. You can screen them on the ICU. They don't need to go into the scanner. They don't need to be relaxed or sedated. You could just do that with anyone. It's quite reliable for muscle dystrophies, motor neuron disease, inflammatory myopathy, and on the ICU. And it's a very valuable tool, more sensitive than the clinical measures for treatment trials in muscle dystrophies. I want to thank you for your attention, and I hope you enjoy your scanning. If you have any questions, just let me know.